Choosing Wisely Canada is a national campaign aimed at reducing unnecessary tests and treatments in healthcare. In this video, we present one of the top 5 dermatology recommendations for physicians and patients, which are set by the Canadian Dermatology Association and Choosing Wisely Canada. Don't use oral antibiotics for acne vulgaris for more than 3 months without assessing efficacy. First, let's start with a case. A 14-year-old girl, Lucy, presents to the family medicine clinic with a 3-month history of progressively worsening facial acne. It has significantly impacted her self-esteem. Her medical history is otherwise unremarkable. On examination, there are many erythematous, small papules and pustules over her cheeks without any dyspigmentation or scarring. What types of acne are observed? How severe is her acne? What treatment would you recommend at this point? Acne vulgaris is an inflammatory disorder of pilosebaceous follicles. It has a prevalence rate of 85% among people aged 12 to 24 years, with 15 to 20% having moderate to severe disease. It is associated with depression and anxiety. There are 4 main factors involved in the pathogenesis of acne. First, there is an increase in sebum production mediated by androgen. Second, keratin and sebum plug the hair follicle, leading to comedone formation. Third, C. acnes proliferates in the sebaceous follicle, leading to the release of pro-inflammatory cytokines. Last, there is an inflammatory response. Acne begins with microcomedone, which is a small hyperkeratotic plug composed of corneocytes in the lower portion of the follicular infundibulum. It can then lead to various clinical lesions, including closed comedones, which are called whiteheads, open comedones, which are called blackheads, and inflammatory papules, pustules, and nodules. There is no universal system for grading the severity of acne. To facilitate therapeutic decisions and assess treatment response, you should consider the following: the number of acne lesions, clinical type of acne, disease severity, anatomical sites, scarring and dyspigmentation, as well as impact on quality of life. Of those, the 2 most important factors to consider when picking the appropriate treatment for acne are the type of acne and its severity. There are 2 major types of acne: comedonal and inflammatory. For comedonal acne, topical retinoid is the first line. The available options include tretinoin, adapalene, tazarotene, and trifarotene. Salicylic acid, which is a lipophilic beta-hydroxy acid, is also effective as it breaks down comedones. For inflammatory acne, topical retinoids can be used because of its anti-inflammatory effect. Antimicrobials including benzoyl peroxide, clindamycin, erythromycin, sulfacetamide, and dapsone are used for their antibacterial action against C. acnes and anti-inflammatory effects. Benzoyl peroxide causes peroxidation of acne bacteria, and this unique bactericidal mechanism of action leads to a negligible risk of antibiotic resistance. Meanwhile, when other antibiotics are used alone, it may promote the appearance of resistant strains of C. acnes. The second factor is the severity of disease. In more severe disease, patients may need systemic therapy and multiple treatment modalities. Available oral options include isotretinoin and antibiotics, most commonly tetracyclines, and less often the class of macrolides, which include erythromycin and azithromycin, and dapsone. Doxycycline has the best tissue penetration among tetracyclines. Be aware of the associated contraindications and counsel patients on the adverse effects of tetracyclines listed here. Other oral options include spironolactone and specific combined oral contraceptive pills for anti-androgenic effects. Side effects of spironolactone may include lightheadedness, breast tenderness, and irregular menses. Potassium monitoring is not required in healthy young adults, but should be considered if a patient has renal insufficiency or is taking exogenous potassium or other potassium-sparing diuretics like ACE inhibitors or ARBs. After deciding the most appropriate therapy for patients, it is crucial to discuss adherence, proper use, and strategies to minimize side effects to reach the optimal treatment outcome. Acne is a non-infectious disease, and antibiotics are utilized primarily for their anti-inflammatory properties. The biggest concern with antibiotics is the emerging resistance. The use of topical antibiotics leads to resistance confined to the treated skin. The use of oral antibiotics can lead to resistance in commensal flora at any body site. Antibiotic resistance can cause treatment failure of acne, induction of opportunistic pathogen locally and systemically, and even dissemination of resistant strains. Therefore, it is crucial to consider antimicrobial stewardship when prescribing for acne. There are different ways you can consider to reduce the incidence of antibiotic resistance, and we will be covering them here. Number 1, make sure that the antibiotics is the right choice in the first place. Antibiotics is used for inflammatory acne rather than comedonal type. Oral antibiotics should be used in moderate to severe acne. 2, antibiotics should not be used as a monotherapy. Topical antibiotics should be used in combination with benzoyl peroxide to decrease antibiotic resistance. Oral antibiotics should be used in combination with other non-antimicrobial topical agents, for example, topical retinoid. 3, never prescribe topical and oral antibiotics at the same time due to increased risk of antimicrobial resistance. 4, the duration of antibiotics should be limited to decrease resistance and possible adverse reactions. Patients should be reassessed at 3 months, and if clinical improvement is absent, other options such as isotretinoin, spironolactone, or combined oral contraceptive pills should be considered. 5, if oral antibiotics are stopped and needed to be restarted, prescribe the same antibiotics the second time as long as it is effective. Switching between antibiotics increases the risk of resistance. Lastly, prescribe a topical retinoid. It has effects on both comedonal and inflammatory acne. Combination therapy with topical retinoid can lead to improved treatment efficacy and potentially shorter duration of antibiotic use. Topical retinoid also has the additional benefits of treating dyspigmentation and scarring if used consistently. Now, going back to the case, given the clinical information, our patient has both inflammatory and comedonal acne of moderate severity. It warrants systemic treatment. Oral antibiotics like doxycycline is an appropriate first-line therapy. A topical therapy such as tretinoin cream every night should be added to increase efficacy. Topical antibiotics other than benzoyl peroxide should be avoided in Lucy's case, as she has already been prescribed oral doxycycline. Concurrent use of topical antibiotics with oral antibiotics leads to increased risk of antimicrobial resistance. You should see Lucy in 3 months' time to decide if the treatment is effective. If it is ineffective, other systemic treatments should be considered. From this video, we hope you understand the CWC's recommendation of don't use oral antibiotics for acne vulgaris for more than 3 months without assessing efficacy. We also provided other strategies to best manage patients with acne. The take-home messages are: consider both the clinical type and severity of acne when planning for treatment. Improper use of antibiotics for acne can lead to antibiotic resistance and corresponding adverse effects. Antibiotics should not be used as a monotherapy for acne, and always consider prescribing a topical retinoid as an adjunct therapy if tolerated. The effectiveness of antibiotics for acne should be reassessed after 3 months, and other systemic therapy should be initiated in the case of treatment failure or intolerance.